Having shown that the absence of clear benefit from mammography screening on breast cancer mortality could only be due to a simultaneous increase in breast cancer incidence, we can try to evaluate the dynamics of these mammography-induced cancers. Mammography-induced cancers consist in excess cancers occurring with a delay after screening. The large excess of cancers that are observed after mammography screening implementation is frequently considered as overdiagnosis. Is this correct? Overdiagnosis of cancer is a diagnosis of a cancer that would never cause symptoms. However, if the cancer is removed, how can we know it would not have caused symptoms? In practice, most epidemiologists consider that an excess cancers over what is expected after screening implementation relates to overdiagnosis. The question is to define what is expected. The year a screening program is implemented, the observed annual incidence increases. The annual incidence in the first year of mammography screening corresponds to cancers that would occur in the same year, that is, the annual incidence, plus the cancers that would occur later. Those are prevalent cancers. The excess of cancers is related to lead time and gives the prevalent peak. This is not overdiagnosis. This is illustrated in this figure, where you can see the prevalent peak related to the first mammogram, followed by a return close to the baseline level. In the absence of overdiagnosis or cancers induced by the procedure, the cumulative incidence should not change. In this example from Henrik Zahl, the first mammograms are performed at the age of 51 years. Actually, the year when a screening program is implemented, prevalent screens involve women of all ages invited to screening. If screening were implemented in 1 year in women aged from 50 to 70 years, there would be a prevalent peak this particular year, followed by a return close to baseline, with only women aged from 50 to 51 years having prevalent screens. In this figure, there is no overdiagnosis nor mammography-induced cancers. Actually, national programs are always implemented in several years, and prevalent screens in women aged over 50 years extend over several years. To evaluate the level of overdiagnosis or mammography-induced cancers, it is necessary to eliminate apparent changes in the incidence rate, which are due to the alternation incidence-prevalence incidence, translating in an increase, then a decrease in the observed incidence. One has to distinguish the prevalent peak related to the first mammograms. We need to study programs where the screening data are available and where the screening has been implemented in a short period of time. The NHS breast cancer screening program fulfilled these conditions. After the end of screening implementation in 1993, prevalent screening occurs mainly in the 50-54 age group. As compared to pre-screening rate, breast cancer incidence in this age group shows a 50% increase in 1996 and does not change later. The increase is due to prevalent screening. The incidence rates in the other age groups in 1996 tend to return to the pre-screening level. However, after 1996, excess cancers appear in a direct function of age. This cannot be explained by a better detection between 1996 and 2005, as there is no change after 1996 in the 50-54 age group. So we can conclude that excess cancers appear several years after screening implementation as a function of age, and this is not related to detection. In the case of in situ cancers, which are detected mainly by mammography, the problem of changes related to detection is less important. The decrease in observed incidence rate during the transition from prevalence screening to incidence screening is negligible. It could have interfered with the observation of mammography-induced cancers, but it has not been the case. In 1993, mammography screening coverage was applied nearly completely throughout the United Kingdom in 50 to 64-year-old women. One would have expected a constant incidence of in situ cancer. After 2005, the total number of mammograms was almost constant in the 50-64 age group, comprising of women ranging in age from 50, having their first mammogram, to women of 64, having had 5 mammograms. Here you can see that when the total mammogram number and the delay after mammograms remain constant from 2005 to 2013, the rate of in situ cancer incidence does not vary much with time. On the contrary, from 1993 to 2005, when the number of previous mammograms per woman was increasing, the rate of in situ cancer incidence increased regularly. However, there was a slight increase in mammography attendance after full coverage. To adjust for this increase, the observed incidence was divided by the annual number of screening mammograms performed in England each year. After adjustment, one can see that the incidence of in situ cancer increases with the number of previous mammograms per woman. The 65-69 age group comprises women which were previously screened at a younger age, whereas the 2 other age groups were not screened. Note that breast cancer incidence does not go back to baseline after screening implementation in the 65-69 age group, because it was not prevalent screening, as the women were previously screened when they were younger. As the observations from in situ cancers suggested that breast cancers could appear as soon as 5 years after mammography, it was possible to look for mammography-induced cancers in a short-term clinical trial. As can be seen here, in the UK age trial, an excess of cancers in the screen group is only observed after the 5th mammogram and 5 years after the beginning of screening. This excess is not explained by the dropout rate. From the data above, one can estimate by trial and error the rate and the range of cancer distribution after one mammography screening round. Mammography-induced cancers can be seen as a mathematical entity representing an increase in breast cancer incidence following the pattern shown in the previous slide. Identifying them requires information on screening implementation and a screening program implemented on a short period involving the largest part of the population in the age of screening. In the absence of these requirements, one can still find some indirect evidence for mammography-induced cancers in the form of a change in the age distribution of cancer as a consequence of mammography penetration. In the USA, the increase observed during the implementation years from 1982 to 1990 is related to prevalent screens. Later occur excess cancers at the time predicted for mammography-induced cancers. After 1990, due to therapeutic improvement, annual breast cancer mortality has progressively declined to almost the half of its value, irrespective of the country or of the screening program. Women outside the age of the program and males were also concerned by this reduction. 10 years survival after diagnosis was improved for each age group. However, the reduction of mortality relative to 1988 was not as great in older age groups, in an age-dependent manner, indicating that the excess cancers were associated with excess mortality. In other words, it was not overdiagnosis. In Sweden, the major wave of screening occurred from 1986 to 1992. Detection resulted in cancers occurring earlier. The effect of detection per se can be evaluated by comparing the first year after the major wave, 1993, to the 5 years before this wave. Only few excess cancers are observed before the wave of mammography-induced cancers, and they occur in younger women. In Sweden, 1997 was the year of the end of the last wave of screening implementation. After 1997, an increasing excess of cancers occurred in older women. In France, where screening has been established progressively, one can see that between 1992 and 2005, excess cancers occurred mainly in older women. These findings can be extended to other countries. In the countries where mammography screening has been performed for a long time, the average age of cancer discovery has not lowered as would have been expected from early detection. It has increased. In conclusion, there is strong evidence that, after excluding lead time, most excess cancers that are observed after mammography screening implementation occur with a delay and in older women. The level of increase is related to the age of the women and the time after the beginning of screening. These excess cancers explain the failure of screening programs. The relationship between these cancers and screening seems obligatory, such that they can only be interpreted as mammography-induced cancers.